And if necessary in future, in the SARC region, we can make it one in a single strategic position in postgraduate education in ophthalmology. And also, I think at this webinar, we will be able to learn that how Bangladesh is running, how Nepal is running, how Pakistan is running, how India and also Sri Lanka. Now I will think that you all people who have joined despite your busy schedule, we welcome you all to this webinar, and Ophthalmological Society of Bangladesh and Bangladesh Ophthalmic Research Forum is highly pleased to welcome, and we hope this discussion will be helpful for our academic purposes. Again, I, Dr. Shams Mohammad Noman, to continue our next program. Thank you.
So I'm requesting Professor Abal Hussain, our guest and special guest and guest of honor, to tell something about this program and do an introduction.
Thank you. Good evening to all. It is really a very great pleasure for me to be here today with this important webinar, that is Postgraduate Academy of COVID era. I can remember that last webinar, I have requested that how we were doing our education, both postgraduate and undergraduate, as because students are learning on online without any clinical. They could not do any clinical, they could not see any clinical patient, rather than they are learning regularly with the online, all the lectures and other teaching. So thank you so much, Professor Sharfuddin, President of Ophthalmological Society of Bangladesh, to arrange this, and also Bangladesh Research Forum to organize this webinar within this COVID pandemic situation. It is very, very important topics, and I will not talk now, as because I am also the panelist. I will stay here and I will hear all the speakers and will give my comments and also give my thoughts with you. So with these few words, let me start, as because time is already we are ahead, and I would like to welcome also on behalf of Asia Pacific Academy of Ophthalmology, as because I am here, I am invited here as President-elect, and we are very much we are also very much busy with our next week, from next week onwards, that for our all type of standing committee meeting, executive committee meeting, Congress committee meeting, and all this within 22nd August, and then our council meeting will be held in September 12th. So everybody is busy, and now we are here, Pakistan, India, Sri Lanka, Bangladesh, and Nepal. So I welcome you all, and all are our very known face. We know each other, and nowadays COVID make us close together within this period, as because we are sitting very time to time, and within very short notice we are sitting all together, discussing all about. And now today's topic will be very much benefited for our student, our resident, and all types of postgraduate student of all the country. Thank you so much. Thank you all.
Thank you, madam, for your excellent speech and introduction.
Yeah.
the slide visible?
Yes.
So welcome to this session. The session on Postgraduate Academy in the COVID era, organized by Ophthalmological Society of Bangladesh and Bangladesh Ophthalmic Research Forum. Today, this session is chaired by and hosted by Professor Mohammad Sharfuddin Ahmed. I want to introduce him. He is Professor and Chairman, Department of Community Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He is also President, Ophthalmological Society of Bangladesh. He is President of Bangladesh Community Ophthalmological Society. He is President of Oculoplastic Society of Bangladesh. He is the First Secretary General, Bangladesh Medical Association. He is the President of Bangladesh Ophthalmic Research Forum. It's my pleasure to introduce in front of you Professor Abha Hussain. He is our special guest and guest of honor and also panelist. She is Director cum Chief Consultant of Ophthalmological Society of Bangladesh Eye Hospital. She is President-elect Asia Pacific Academy of Ophthalmology. She was the first President of SAARC Academy of Ophthalmology. She is the first President of Ophthalmological Society of Bangladesh. She was Founder President Bangladesh Community Ophthalmological Society. It's my pleasure to introduce in front of Professor Namrata Sharma. She will join later on. She is cornea cataract and refractive surgery service. She is the Professor of Cornea Cataract and Refractive Surgery Service, Dr. Rajendra Prasad Center for Ophthalmic Science, All India Institute of Medical Science, New Delhi. She did a fellowship from Wilson's Eye Hospital, London, UK. She is the Honorary General Secretary of All India Ophthalmological Society. She is the Regional Secretary, Asia Pacific Academy of Ophthalmology. It's my pleasure to introduce you Professor Dr. Nazir Ashraf Ladhari. He is the Vice Chancellor, Isra University, Sindh, Pakistan. He is Dean, Faculty of Ophthalmology, College of Physicians and Surgeons, Pakistan. He was the member, Executive Committee, Ophthalmological Society of Pakistan, and he was the first President of Ophthalmological Society of Pakistan. Our next panelist, Professor Hazrat Ali, is President, Bangladesh Academy of Ophthalmology, the Consultant Eye Surgeon, Harun Eye Foundation Hospital, and ex-head of the Department of Ophthalmology, Ardem Hospital. I'm really delighted to introduce in front of you Professor Dr. Sagun Narayan Joshi. He is a panelist and also a speaker. He is the head of the Ophthalmology Institute of Medicine, Tribhuvan University, Nepal. He is the life member, Nepal Ophthalmological Society. I'm introducing as a panelist Professor Dr. Sarwar Alam. He is the Director Education, Professor of Cornea Segment, Isfahani Islamia Eye Institute and Hospital. It's my pleasure to introduce in front of you Professor Jafar Khalid as a panelist, the Chairman of Ophthalmology Department, Bangabandhu Sheikh Mujib Medical University, and he is the Consultant, Bangladesh Eye Hospital. Our next panelist, Dr. K. A. Salvin, is the Senior Lecturer, University of Kelaniya, Sri Lanka. He is the President-elect College of Ophthalmology of Sri Lanka. It's my pleasure to introduce in front of you our another moderator as well as panelist, Professor Abdul Kader. He is the Secretary General and Ophthalmological Society of Bangladesh. He is the Professor of Cornea, National Institute of Ophthalmology and Hospital. He is Director, Bangladesh Eye Hospital Limited, Uttara, Dhaka. And this is Dr. Noman, the Senior Consultant and Head of the Department of Glaucoma, Chittagong Eye Infirmary and Training Complex. I'm the Member Secretary of Bangladesh Ophthalmic Research Forum, General Secretary, Ophthalmological Society of Bangladesh, Chittagong, Council Member, SAARC Academy of Ophthalmology. Thank you so much. Now we will start our session. All speakers, we will have 12 minutes, and we have the same topics of discussion about the postgraduate education, ophthalmic education, especially in the COVID era, what we are doing, what we did, and what is our future plan. So I am requesting Dr. Professor Sagun Narayan Joshi to start his presentation. Professor Sagun sir, now the time is yours. Thank you.
Can't hear you.
Yeah. I have to share the screen. Do I have to share the screen?
Now, yes, we can hear you now.
One second, I need to get my presentation. I'm getting my presentation.
You share your screen.
I need to share my screen.
Yes, very good.
Yeah.
Yes.
Give me a moment.
So,
I'm getting it. One second.
can you please
Any problem?
go to the file and open the file, and then you can share it, sir.
Okay. Let me just get to the file first. Get it down. Okay. Can you see?
No, still not.
No.
Can
Okay. I got my thing here. Now I need to share it. Oh,
I think you stopped sharing everything and it is starting.
yes, yes, yes.
Okay.
I need to share my screen. I'm not being able. Okay. That's coming. One second. Are you able to see it now?
Yes.
Yes, yes. Thank you. Now it's okay.
Yes.
Can you please start your large screen?
Yeah, I'm just doing that.
Thank you.
Okay. So this is, if you see a picture, this is the picture of my institute, the BP Koira Light Center for Ophthalmic Studies, which is actually under the Tribune University. So we've been running this postgraduate since the past 33 years. And I myself have actually graduated from there. Now, a little bit about, so a little bit about the current scenario during this COVID era in our center. Before that, the first case of actually this COVID case first landed up in Nepal in 23rd of January. And the patient was a student from Wuhan. But we were luckily to isolate, we were able to identify this patient, and we were able to isolate it and put it in the hospital, and things were fairly under good control, and the lockdown in Nepal started one day before India. That was 24th March 2020, and things were very well controlled. And then finally, when everything started getting eased down, we finally in Nepal, the government decided to ease the lockdown on 21st July 2020. That's when all the cases started rising. And if you see this map, the pink area, the dark pink or the purple area, these are the hot spots, and that's mostly lying across that the place where this increase is probably in the border with India. So most of the cases have actually been imported from India. So total case till date is approximately, according to government officials, is around not 24 today was around 25,500. Fortunately, our mortality rate has been very low. I believe one of the lowest, actually 0.3%. So there may be many reasons for it, especially in our subcontinent. is when this COVID entered our country and things, we wanted all these things under control. The first thing we did was we had to suspend the OPD, the routine OTs, academics, including all our satellite postings which were in the peripheral part of the country. And all we did was give emergency services and inpatient services. And the entire backbone of our entire service was because of our residents. So hats off to them. They were always in the front line. On April 24, 2020, we finally decided to resume our OBD services and academics with restrictions. So till then, we didn't have any other thing except emergency and inpatient services. Now what happened? Restriction on academics. So we went totally on online classes. So we just had 3 classes a week. And unfortunately, the students, all our exposure, surgical exposure came to minimum. Only when we started doing only selected cases, and because we didn't know how to work with it, so our residents unfortunately didn't get very good surgical exposure. Special clinic postings were merged with general clinic postings. Now, if you see, this is a picture of my resident actually seeing a patient, but my residents were clinically exposed. They were clinically exposed all the days. How we did it was this. The restrictions we had in the OPD was, of course, we made sure that everybody is well protected. That was the most important thing. Apart from teaching them, the most important thing, make sure they are well protected. So they were given appropriate PPE, and we trained them in how to don and doff, and proper physical distancing was maintained among all ourselves and also among the patients. This was very important because we didn't want any infection coming in our institution. Because once any infection got into any institution, the government would just seal the institution. So we made sure that we followed these things very well. With proper mask was compulsory for everybody, including patients. Physical distancing of 2 meters among ourselves as well as among the patients was maintained. And we also had trained spotters who would do the thermal scanning as well as control the crowd. If the crowd is not wearing the mask, they would make sure that the crowd, the patient is wearing the mask. And we also, ourselves, resident faculty, ourselves, would be moving around, helping the spotters to maintain this physical distancing as well as that the patients are wearing their masks. Sanitization that was one thing that we did. All the hospital was sanitized after every OPD, and we had sanitizers everywhere entry of the patient. So this was given utmost importance. We also decided that make sure that our students don't get exposed, or we don't get exposed to this virus and get infected. We decreased the number of patients. We used to see around 300 to 400 patients, averagely around 400 patients a day. We reduced it drastically to 50 plus to 60. So brought down the number of patients to this 50 to 60, so that we could maintain the social distancing as well as make sure all the sanitization was well maintained, and we could control the crowds. You see my students, the students, they were at the front line. They were always in the OPD seeing all the clinical cases, and there would be around 2 faculties, and these faculties would be staying in a room. Any cases that had to be discussed, the faculty would be rotating and coming to that particular room. The patient was not allowed to move. Once the patient moves in, the patient straight away goes and sits in the split lamp. Whereas the patient party is put a little away from the patient, whereas the resident or the faculty sees the patient, but comes back here. They maintain the social distance. All the history is taken from the chair this side, but the student is allowed, we tell the student and the faculties not to spend more than 2 to 3 minutes on the slit lamp. And the slit lamp also has these guards. We are made of acrylic, big guards, and make sure that there is no droplet infection. And students and faculties, we also divided ourselves into 3 groups, and we used to come twice weekly. And further, when things got a little worse, or when we didn't want to expose ourselves, we further subdivided into 6 groups depending on the situation. Right now, we have come back to 2 groups. And all the aerosol generating procedures were avoided, making sure that our students are not infected, because if one of the students get infected, we all would have to test ourselves. We also went into telemedicine services. Now, regarding surgery, there were a lot of restrictions. We had to cut down our surgery numbers. We had to group the OT staff and surgeons, and all elective OTs were actually postponed. Cataract surgery, retinal surgeries, and emergency surgeries were done after PCR procedures only. Short procedures, intravitreal injections were given without PCR, but also the crowd control was very well maintained there. Now, we also had this triage, we had something called the COVID room, and we had quarantines and isolations. We had a triage for suspect COVID or COVID cases, where if we felt that the patient is suspicious for COVID or is from a hotspot, we had a separate COVID room where one resident and one faculty was designated, where the resident would look at the case, and if necessary, the faculty would come and see. So a separate place was made for just COVID suspects and COVID cases. And if any of us, including students, faculties, if any of us was suspected, if we suspect that we may have had infection or we got exposed, we had the options of home quarantine. Even the hospital we also maintained hotel quarantine, and if absolutely necessary, we have also rooms in the hospital for hospital quarantine for our residents as well as for us. And we also, since we are attached to a general hospital, we also had an isolation ward where if anybody is infected, we can be shifted to an isolation ward. So we've been attached to a general hospital. So we do get quite a number of COVID cases. Now, we just finished our postgraduate examination this time, just around a week back, and we had 7 students, and we had to change the whole scenario of the exams. Like before, we used to take the exams. The patient used to be right there, and we used to put the patient there. The students would see the patient, and we would see the patient, and we would ask questions on it. But this time, what we did was we just took for the postgraduate one short case, one long case, and we had Viva, and also these instruments and all that. So short case, we made a virtual case. We had virtual cases with photographs, and the student was, the case scenario was given, and the questions were asked accordingly. But for the long case, we did have one case where the students wore their PP, and they were given half an hour, just not more than 20 to 30 minutes to look at the case. The examiner would also look at the case, and then they would come back, and then we would ask questions on that. So we normally used to have one long case, 2 short cases. We used to have a lot of other, like we used to have a refraction, we used to have retinal examinations. All this we had to just cut it down, and the students were taken. The exam was taken in a seminar hall with social distancing, and each student was examined for only 30 minutes, not more than 30 minutes. So we had 3 days of exams. So all days they were supposed to come in 3 days of exams every 30 minutes each of the days. So this is just a picture to show you how we have taken the exams with the mic system, everyone maintaining the social distance, wearing masks to make sure that nobody is infected. So here you could see that one of my residents fully protected and the patient there. So he or she actually sits at least 2 meters. It's more than 2 meters, at least 2 meters, and the history is taken from there. And from that table, they go to the slit lamp, examine the patient, and come back. So during the slit lamp examination, they are not supposed to talk. And here, these you see are the students. You see my students. They were giving after the exam. We took a photograph. These are the students. So this is how we prepared ourselves. Now, fortunately, we could say in Nepal, none except one. None of the ophthalmologists have got COVID so far. We only had one ophthalmologist who got infected in Viratnagar, that is bordering to India, and she was infected because she worked in a general hospital, but she finally has recovered. But none of the ophthalmologists so far in Nepal have got infected with COVID. Now, regarding the future plans, this is a very difficult question to answer because we are changing day by day depending on the situation. Now, the number of cases are increasing gradually. We we took one step forward, now we've come 2 steps back. So with the gradual easing of restrictions, we are making newer protocols and we are safeguarding our students and ourselves to make sure they are not infected, because their health is more important. And teaching, yes, we are teaching, but not in the way we used to teach. Clinical teaching is there, but not like before. But we are gradually adapting to the situation, and hopefully we'll be able to get out of this. Thank you very much. So this was after the exam. This photograph was taken just for a minute. We got together, took a photograph of all our students who were just given the exams. Thank you very much.
Thank you. Shagun Naran Joshi, thank you very much for your nice presentation.
Dr. Mohan?
Sir,
Just to
hello.
Okay, Naman?
Hello.
just to off your screen share.
Yes, you off.
Thank you. Okay.
Uh,
Okay.
Thank you, Professor Shagun Narayan Joshi, for your excellent presentation. You did really very well in your situation in this COVID era. I think we will discuss later on after ending of
Yes.
all lectures actually. So I am requesting Professor Sharfuddin Ahmed sir to deliver his presentation. We have the same topic, what I have already told. The Postgraduate Academy in this COVID era, what we did, what we are doing, what is our future plan. Thank you, sir.
Okay.
The time is yours.
Okay, thank you very much. I think the how will you treat the patients during the COVID regime? India, Bangladesh, Nepal, Pakistan all have made their plannings, and we have already have our guideline from Ophthalmological Society of Bangladesh, and you see what Shagun Naran Joshi told, that during COVID era, what we are doing. First of all, in 8th March in Bangladesh, we got 3 patients on 8th March. Now you see 3,500 people have already died, and 2.5 lakh people already attacked. And in your country, it is only 24,000 in Nepal and only 0.3% dead. So they have restriction, and from the very first day, Nepal has controlled it. Nepal, Vietnam, Kerala, we all told, we are already give the example that they have controlled. But in our country, in postgraduate education, we have seen some of the problems that still during last 6 months we have no examination. What Nepal has already done, we are still only on online classes, and we are working on these online classes 3 days in a week, and also we are performing our OPD, emergency operations, and in our country the same thing, trial system, thermal scanning, sanitization, all are going on. And the slit up examination by our residents, where it is necessary, with the breath shield, everything is going on as before we told. I want to share you with the postgraduate education in Bangladesh. Hope we will be able to perform our examination probably from January. That is, during this period, maybe in September, thesis examination, but clinical maybe started in January 21. So we are going back for 6 months for our residents, which you have performed in your country, but we could not. Now I will say about the degrees, what are going on in our country. I hope you will also share what degrees you are performing and how long you are giving their course duration. That will be helpful for us. Ophthalmology is one of the most desired subjects for postgraduate education, a lots of course program are available. Who are the institutes? Bangabandhu Sheikh Mujib Medical University, which you have already mentioned about the Tribhuvan, AIMS everywhere, even Pakistan. And another one is Bangladesh College of Physicians and Surgeons, and also Dhaka University. Post-graduation is going on. And what are the degrees we perform in Bangladesh? MS in Community Ophthalmology, MS in Ophthalmology, Diploma in Community Ophthalmology, and Diploma in Ophthalmology. These are the degrees performed in our country. And this Bangladesh College of Physicians and Surgeons, they give the MCPS in ophthalmology and MCP. And I want to mention about the MS in Community Ophthalmology. Community ophthalmology generally deals with the promotion of eye health and prevention of congenital, developmental, hereditary, communicable, environment, and age-related ocular diseases. It specifically aims to ensure quality in the delivery of eye services at the community. And the sole purpose is to prevent and reduce the eye diseases. You all know it. The course is 5 years in our country, postgraduate training to achieve the required level of knowledge, skill, and expertise in ophthalmology. And program outline is entry criteria medical graduates and 1 year internship. And then phase A, foundation training will be there, duration 2 years. Parent department will be 6 months, and surrogate department will be 15 months, and phase B will be community ophthalmology training, and duration will be 3 years. Admission test with MCQ and 200 questions, and date of commencement March of each year. MS in ophthalmology, program supervised by BSMMO and run into different institutes in Bangladesh. 5-year intensive postgraduate training to achieve the required level of knowledge, skill, and expertise. And program outline medical graduates with internship 1 year, and phase A 2 years, and parent department 6 months, and phase B 3 years. And admission test is as before. And diploma in community ophthalmology, it is also performed in Institute of Community Ophthalmology, Chittagong, CITC, and duration is 2 years, and it every July it starts. Eligibility medical graduate as well as minimum 2 years after passing MBBS. Admission test with MCQ, and there is the basic community ophthalmology and ophthalmic medicine and surgery. And diploma in ophthalmology, recognized course BSMMU 2 years, and also admission test through MCQ. And FCPS in our country is being performed by Bangladesh College of Physicians and Surgeons, as probably it is also in Pakistan. In India, there is no College of Ophthalmology, but there is also in Sri Lanka, there is College of Ophthalmology. The FCPS Part 1 examination, after that there will be training, and then Part 2 final examination. Part 1, the examination, entry criteria, medical graduate with internship, date of commencement every January and July of each year. And there will be the paper 1, paper 2, paper 3, and training course 3 years training, and there will be 1 year course, and also without course there will be 4 years training, and there will be the final examination after the completion of the training. And there is another course in MCPS in ophthalmology in our country. I don't know in other countries it is present or not, but in our country this course is going on, medical graduates, and 1 year residency training in the respective subject. And after passing 4 years after graduation, they will be able to get this MCPS examination. And I wanted to mention all these things because our neighboring countries, they are also performing this. I know during that day, Namrata Sharma, who mentioned that in their country, the post-graduation MSc is only 3 years. Also, Nepal is also have MS 3 years. But in our country, MS is 5 years. Also, FCPS is also 5 years. So, what is the difference between these two areas? That is 3 years and 5 years. That can be also discussed today by our panelists, and whether we can make it in the mid position or it will be helpful or not. And again, what we will do after the COVID era and why we are waiting.
वो कहीं दूसरा ले ले वो
Yeah,
आजकल बेस्ट है वैसे
okay. So this is the one thing. Another thing I want to mention
दूसरा इनके पास पड़ा होगा
that after the COVID era, probably new normal life has started. Whether we can start our examination immediately and how we can, as Nepal has started, India has started, why we are going back. It will be helpful by the discussion of our panelists, because all the panelists, I think they are the examiners, and in our country we can also discuss about this examination during this COVID era in postgraduate ophthalmology education. And another thing I will also request to all of you that why the elective surgery is being stopped in some of the institutes, whether we can start it immediately or not, and what will be the situation in the cataract backlog, as because no eye camps are also going on. So with this thing, I will want to conclude, and I hope the panelists will discuss here, and also postgraduate education in ophthalmology, how we can improve. You can also give us your directions and your idea. With these few words, thank you very much for patient sharing. Thank you. And stopping.
Can you please?
Yes, I stop my.
Thank you, Professor Sharfuddin Ahmed, sir, for your excellent presentation, and it will guide us to plan our future. I am requesting Professor Nazir Laghiri, sir, from Pakistan. He is the Vice Chancellor of Isra University, Sindhu, Pakistan. So I am requesting you, sir, can you please explain your experience through your presentation? And the
For
time
that,
is yours.
we will welcome our Professor Namrata Sharma, who is also joined with us. And after the presentation of Nazir Laghari, I hope she will present. Okay, thank you.
Yes.
Thank you very much. First of all, thank you, Shams, for organizing this beautiful forum. This will go a long way to participate and to exchange the ideas in every possible way, and we will learn, and in return, our patients will benefit at the Lord. Do you have my presentation, Dr. Oman?
Yes, hello.
You want to, or I can go without it? Do you have my presentation?
You don't have your presentation with you?
All right. No. I didn't upload it, but never mind. What I was going to say, whatever Professor Joshi said and Professor Sharafuddin Ahmed said, it's more or less same thing what we are facing here in Pakistan. When we started COVID, the things were not too bad, but our lockdown was different in different provinces because of the government regulations. And then slowly, gradually, we tried to control it and then eased that down. But then we had another peak, and then again we came down. So as for our scientific skills and surgical skills concerned, to start with, we stopped all the elective surgery. We reduced the OPDs to minimum from 500 to 600 a day. We reduced to the 50 only, observing strict SOPs, strict distance, social distancing, gloves and masks and sanitization and the thermal checking. That was very strict, and not only on the patients but the staff as well. Cleaning and fumigating of the areas was done minimum twice a day, and that way, alhamdulillah, that we have control in a better way the situation. I'm sorry, I was lucky to hear from Professor Joshi that they did not lose any of the ophthalmologists during this COVID problem, but we are sorry to say that we lost one of our great colleagues, ophthalmologists from Islamabad, Professor Nakash, who died because of this COVID. So we're sorry for that. So we have suffered from that. As far as our education is concerned, we are still online, our students, our postgraduates, undergraduates, we're still online, and we are hoping that slowly, gradually, we bring them back, and especially in our university, we are going to bring them slowly, partially from 15th of September. This is the government guidelines we got and from our Higher Education Commission that we start from 15th of September, when we only bring the fourth year and final year MBBS students, and then October, middle of the October, we bring the third year, and then end of the October, second year, and hopefully by the November, December, if the COVID status remains same as it is today. It is on a decline, unfortunately, in Pakistan. Every day, numbers are going down, so which is very good, very fortunate. We are a little bit worried about our Muharram coming. Whether in Muharram Sharif, you know, there's a lot of gatherings there during the Muharram, and during that we are just a little bit worried that we may have second wave of this infection, but we are taking very strict measure to contain it, and hopefully, inshallah, we will contain it. As far as the post-graduation is concerned, post-graduate exams are at halt at the present time. We are not taking any exams of post-graduation, but the postgraduate teaching and learning online is there all the time. The online teaching and learning problems are there. We are, you know, and I know, and every one of us know that they are there, especially this connectivity problem, especially the people who live in the rural.
Mr. Laghari, please unmute. You unmute yourself. Mr. Laghari, yeah.
Yes,
Thank
yes.
you.
Is it okay now?
Yes, it is okay.
Thank you. Thank you. Yes, this is again what we are facing. Our students are facing these problems as well. So, but still, what our statistics in our university shows that about 90 to 93% of the students are beneficiary of this online teaching and learning, but there is still 6 to 8% people who are losing this important line, this important teaching. But still, I think we should carry on, and probably this is the way forward for our all the nations to come, and we are all learning new things every day, the which way to tackle this way of teaching. So this is what I have to say. Otherwise, I think it's almost a mirror image what Professor Joshi said and what Professor Shamsuddin said. It's exactly the same thing what we're doing here. Our postgraduate exams are same as Professor Shamsuddin said, the diploma in ophthalmology, master's in ophthalmology, and FCPS fellowship in ophthalmology. Our time period of the courses are different than yours. We have here 2 years diploma, 4 years master's, and 4 years FCPS fellowship training. But after that, we don't give them straight away the title in the university like assistant professor. After getting fellowship, we make sure that they have 2 years clinical experience before they can be appointed as assistant professor. In olden days, remember when we had a fellowship, we got straight away the assistant professor job, but it's not there anymore. But with the time, we are learning everything, and inshallah, we get there where we want to be. And if the students, the teachers, and the public's cooperation remains same as it is today, then I'm sure we will succeed at all platforms. Thank you very much indeed.
Thank you, sir. Thank you, Professor Najir Laghari, for your nice presentation and the nice scenario in Pakistan. Now, may I request our next speaker, Professor Namrata Sharma. She is Honorary Secretary General of AIOS. Please come to presentation your space.
Thank you, Shams, for this opportunity to be here on this platform. And I think as teachers, we all like to be worried, and we all like to find out ways and means of postgraduate teaching, how to make it simpler, and especially so in the COVID times. Last time, I think I talked about it, how we are still going ahead with the postgraduate teaching program. So in our country, we have MD course of ophthalmology, which is there only in RP Center Ames. Rest all over the country, it is MS ophthalmology for 3 years. Then there's a diploma in ophthalmology course for 2 years. Then DNB ophthalmology course for 3 years. Then after that, after doing their post graduation, people like to do either senior residency, which is for 3 years, which is there in the government hospital, or they go in for fellowships, which is there in private organizations. So senior residency is there, for instance, in RP Center, which is a government hospital, or in Guru Nanak Eye Center, again a government hospital. And fellowship is there, program is there in institutions like LB Prasad Eye Institute or Arvind Eye Hospital, and the duration would vary from 3 months to 2 years. Now, I think for a post graduation, these things are must. That is clinical skills, which requires the workup of the patient's investigations and treatment. There are no patients except for the emergency patients, so our postgraduates are working up only those. We do have a casualty at RP Center, which runs 24 into 7. So they did during the COVID times do perforating injury repair and all the emergency cases which came, but unfortunately, during the lockdown, our emergency was also came down to the level of 110 as opposed to what it used to be in last year during the same time period. Then, as far as the investigations are concerned, people were scared, residents were scared, we were scared, patients are scared. So, no contact investigations were only done if really it was necessary. And of course, treatment was done. Another thing which really came into being was the teleconsultation, and teleconsultation was something which has really increased, I think, over across all countries. Only thing is, for ophthalmology, except for few diseases where it is helpful, it may not be helpful, for all diseases, because you do require special instruments to see. But it was a good tool, especially if the patient has shown. For instance, it was a keratoplasty patient who's already shown to a general ophthalmologist, and who sends a picture to you, then you can always give your opinion. Then, as far as the surgical skills are concerned, like I said, emergency procedures were still going on, although they had decreased, and elective procedures were completely embattled. Even in RP Center now, we have just moved to the level of 30% as what our load used to be as compared to last year. The second issue was thesis or dissertation. What to do about this? Because postgraduates do have a problem who have been allotted thesis. So first year students, they were not recruited because they could not join. They joined, all of them have joined late. Third years have got their extension further for 3 months because they lost that much time. Second year students are midway in learning because they've already learned for 1 year, but they don't know what the future holds, especially about the surgical training. Third year students again have a problem because they have to submit their thesis and they have to face the postgraduate examination. There were also people who gave exams. We have exams in January and in June. So the June batch had to give its exam, which was again held virtually, like I mentioned last time also. Compounding to this problem was that our residents were, although in ophthalmology, were posted in the COVID area, so Ames, Jajjar and Trauma Center were COVID hospital. At any given time, although we do have about 200 plus residents, but 40% were posted in COVID duties, 40% were in quarantine, and 10% were available at that time. Although we shouldn't complain because the workload also was not there, but for students who do COVID duties, it is quite mentally taxing and also physically taxing. And when we held virtual classes, people who were in COVID duties could not attend those virtual classes. This is just to show how on a Zoom platform we started virtual classes, and all the students, they now every Wednesday, or as depending on the unit, every week they are there on a virtual platform where virtual cases are presented. Now, how MD exam was conducted? It was a big challenge. There were total of 28 students for MD exam, and written exam was taken physically for them with social distancing. So there was a big hall, and all the students were made to sit. They wore N95 masks, they wore gloves, they wore caps, shoe covers, and they wore disposable gowns to give the exams. Then for the practical exams, all candidates and the examiners wore PPE. And this again, of course, is an additional cost because you require 40 PPEs because 28 candidates and then other people who are involved in the exam, which includes the external examiner, the internal examiner, people who are helping with the exam, and the exam lasted for 3 days. So we had external examiner one who was from Delhi only, so we didn't have to get that person from anywhere. And external examiner two was from PGI Chandigarh, who was virtually linked to us on video conferencing. So all the cases, the long case, short case, quarters, they were numbered and virtually on a digital platform. This was shared with external examiner one and external examiner two, as well as amongst both the internal examiners. And whenever they wanted to allot a case or they wanted to refer a case, they would just say from that virtual computer laptop that this is, case 35 or this is case 32 that they are talking about. Then packed food was made available for students and examinees both. Buffet, of course, was not possible and there were issues with hygiene even with the packed food. And case scenarios were given instead of patients. And we did have instruments, surgical videos, etc. They were projected. It was not possible to physically hand over the instruments. So they were just projected on the laptop. This is the pattern that we follow. So on day one, we give them a long case, one batch, and the other batch takes another long case. Then there are pieces which have to be presented, as well as surgery, viva, refraction, PMD, and orthoptics. I'll show you examples of all. Then we had short cases and spot cases, then long cases where we gave them history and investigations, and they had to tell about the treatment, or you gave them history and then you ask them what investigations would you like to do. So they'll tell you, okay, I want ASOCT or I want specular microscopy. So you would immediately on the laptop only show, okay, this is fixed dystrophy and the specular is this much. Now what will you do? So it was something like that. Then we did have surgery, viva, refraction, PMT, orthoptics, everything virtually. This is presentation virtually. Spot and short cases, grand viva. Then we showed ocular pathology, microbiology, slides to them, then showed instruments to them. Nothing was touched by hand. And all of them wore PP, and then we also did grand viva. The format was that all the cases were allotted at bedside only, and they were given lots. They never moved. They were designated places where they just sat the whole day, and there only they had to choose the lots, and whatever the number is, that case printout was given to them. So they, after seeing the printout, they were called for the viva. There was an orthoptics case. Just to give example, we showed them like this on a laptop, and then we asked them questions. If it was a refraction case, then we again made this and then asked them under if refraction is done under HA, then what do you think you would subtract? So everything was virtual. Then we had prepared catalog of surgical videos. So all the videos from consultants were got, like emulsification, triple procedure, host trepanation, VSEC, LASIK, ICL, etc. And then we played them virtually on the computer and asked them questions there only. Then as far as the thesis is concerned, what to do for thesis during this time? Now our ethics committee did relax certain rules. People who wanted to submit the thesis, appropriate extensions were given for submission. If everyone has been extended by 6 months. Then the prospective studies have been converted to ambispective studies and revised protocols have been sent so that whatever has been done prospectively, we don't know how many cases we will get. So we've now added retrospective component to it so that they can just see the case records. Then follow-up of the patients have been shortened. So earlier they had to follow up for 6 months. Now we told them, okay, whatever follow-up you have, last follow-up, we stop it at that. Number of patients which are to be recruited have been decreased and appropriate corrections have been sent to ethics committee. And they have been quite liberal in allowing this. But this is just to show how clinical spot now. We just show them this. This is the clinical spot. What is your diagnosis? So they'll say what is your diagnosis, then we go on to the treatment. For instance, what is this investigation? What is your diagnosis? What marks do you see? So on this only, virtually only we tested them, or we showed them this, giving them some brief history, leukocoria. This is HNE stain. So what is your diagnosis? What do you see with the arrow? So this our ocular pathologist gave slides like this, and like ocular microbiology as well. So if a patient is there, we gave some virtual history, and then we said, what is this? What do you think stain has been used? What is the treatment of this case? Likewise, for radiology report, identify this, where is the lesion present, what do you think is the differential diagnosis. Then instruments, again, we couldn't allow them to touch, so we just made pictures of the instruments also and showed them like this. Likewise, for pharmacology drugs, okay, what is the percentage of this drug, what are the contraindications where you will not give, and what is the name of this test, for instance, what is the principle. So like this, we had to work a little bit on a virtual platform, but we did, put pictures and maps to give them questions, etc. And these are the at the end of the this thing. These are the students after they finish their exam. This is how they were dressed, wearing PPE, and this is just a picture to show that all 28 of them have passed, and now they have been they finished their MD. And this I'm just showing that way how these students will learn. This could be one way they can only see and maybe some can assist, but as of now all surgeries are being done by faculty members only. This is one picture that I just wanted to show you because I went to take exam in Guru Nanak Eye Center as an external examiner. So in their auditorium only, they had made the candidates seated far away. So two set of examiners are here, two set of examiners are there. Everybody is sitting far up, and here in the seats the examinees are there. There were only 4 candidates. So this is just to show again the same platform was there. We were wearing gloves, and on the computer only we showed them the images and we took the exam. So even Delhi University took the exam like this only. So I think these times are testing and times are trying, but we do have to take a step forward. Whatever has happened, and we don't know how long the situation is going to last. So this is what we've done. All senior residents have also been extended by 3 more months if they want it. If they don't want it, it is okay. But almost 99% of them have taken an extension. We do have a surgical skill ophthalmic lab there, and again they are practicing. We can't get both sides, but we have synthetic eyes on which they are practicing, and then we have a simulator. Of course, it is very expensive to have a simulator, to buy a simulator, but they are doing later appointments which are given with physical distancing. We've increased our hours. Earlier, the surgical skill development wet lab was only open till 5 p.m. Now it is open till 9 p.m. and we put staff in on shift duties so that somebody is always there and they are kind of trained. But of course, I think for them also it is a very it is a very difficult and a different time. They don't know about their surgical training, especially the ones who joined as first year senior residents. They don't know when they're going to start. And I think the worst program that has taken a hit is the eye banking and eye donation program. There are no eyes at all. You don't know what to do with perforated corneal ulcers. You don't know what to do where you require tectonic grafts. You don't know what to do with cases where eyes are really required. So that has taken a hit. As soon as this happened, lockdown was announced. Whatever eyes all of the eye banks had, they put it into glycerin because in glycerin you can preserve it for 1 year because we didn't know what the situation would be. So that is what we did, and we are doing all our therapeutics with the glycerin preserved eyes. So I think our government is a little liberal because it allowed all these virtual exams, and I think across all SAARC countries, we will have to tell our governments to be equally liberal, considering that these are COVID times. I know ma'am had asked this question last time also that how can you ask these people without patients? But I think there's also what we also looked at was internal assessment, and all of them we have internal assessment, and that is the reason why we just took it forward, and that has happened across all subspecialties, whether it was medicine or it was surgery or it was even super specialties, cardiology or it was gastroenterology, PM exams. So that is what they have done in India.
Thank you. Thank you, madam, for your excellent presentation and also some pictures of taking exams and that was really very interesting. So we have some questions I think we have completed our presentations. Now we can discuss on some questions. Among the panelists, if you have any questions to each other, you can ask. And now I want to start one questions from the audience. That the virtual examination and true examinations. Now, there is a basic difference, because in the virtual examination, the examinee don't touch the patient. So, but in case of so in the virtual examinations, is there any perfect diagnostic tools can he get, or can you assess perfectly actually from this virtual examination? Can you so there is a basic assessment difference. So how do you think about it, Professor Namrata Sharma?
No, I agree there is a disadvantage because you can't feel if there's a swelling, you can't feel, you can't palpate, you can't examine, and you are helplessly dependent on whatever static pictures are shown to you, and you can't defend your diagnosis. There is only one diagnosis to the picture, the rest of it is a differential diagnosis. So that sort of a fatigue is there, but I think that is something that we will have to. How long will you hold them on to this year? That was the only reason why I think our government took the decision that gave us permission to hold virtual exams across all universities. So that is a thing, but physical examinations, surgical, real surgeries can never, can never be replaced by virtual examination. This may be a temporary arrangement, but this cannot become a permanent feature.
But Professor Namrata Sharma, we think that still we are in new normal life. So, as the examination concerned, whether we can physically give the patients with PP, and with the PP, if we give the patients for physical examination, is there any problem?
No, I think now there should not be a problem. Like just like you see the patient in the OPD, you mask the patient and make the patient sit on a slit lamp, and then there's a breath shield.
Yes, yes.
So I think that can be done because ours was in early June. So that is why they just went ahead with it. But now, from
We
June
can start.
until now, even in Delhi, the situation has changed. We've reduced our cases by almost 50%. So when the situation gets better, I think we can do it with all universities. We'll have to live with it, I guess.
Yes.
And that's something that you cannot now deny that it's not going to happen.
So I'm requesting Professor Jafar Khalid sir to comment on that. What is your thinking about this virtual and real examination procedure, and what is your personal future plan? What should be done?
Okay. Okay. Thank you.
আমি unmute করতে actually.
Sir, please.
Thank you. Thank you very much, Dr. Noman. I was listening very recent experiences of Dr. Joshi from Nepal, Dr. Lagari from Pakistan, and also Dr. Namrata was presenting very nicely. And at the same time, from Bangladesh, Dr. Sharfuddin sir was also telling about our experience. So I'm really worried about the future. I'm not very concerned about the Bangladesh has skipped the July exam in the College of Physicians. They could not take the exam in the July. Our university, the Bangladesh Medical University, could not take the exam because we could not just didn't have any permission like that. Our university gave us any permission to go for a virtual exam, so we could not do it. But those who are in the final stage, they can be taken. Then this exam can be arranged in the next few months. So that should not be a problem. So as Dr. Namrata has already told that with the PPE, with a limited clinical scenario, we can give normal patient, bring the normal patient in the exam room, and we can do that if possible. But the major concern is that doctors who are already in the training, the middle of the training or the beginning of the training, we are not able to give them proper clinical skill, proper clinical skill, as well as they are already almost starting the thesis process. These are the issues which is to be brought into the focus. And we are trying, as you know, we are trying to cover it up with the online classes and Zoom classes. And our residents have already started working in the OPD, seeing the patients since June. They could not see any patient from March, April, and May, but from June, we are allowing them to see the patients. But the thing is that it's not a normal thing. Practically, the residents practical demonstrations are much less nowadays. We are distancing totally distancing with the patients. Even the supervisors and the residents do not sit very close. So it's not very easy to demonstrate the clinical skill to the residents. So what will happen if it is continuing for a long time? Maybe the next year or after that year, we will see the real problem, whether our future residents are getting less clinical skill and surgical skill. That is, I think, the major issue in future. As the Delhi from Delhi, Dr. Namrata has shown us how to take a virtual exam. Maybe we'll be able to organize something like that. Just to mention that we were trying to take the thesis defense exam this week, and finally our university authority has postponed it for another month because of these distancing issues. Because in Bangladesh, the scenario is a little bit different from other countries. Like we have a very high 20% infection rate among the tested people. And but fortunately, there is a low death rate. It is around 1 to 2%. But the scenario which is worrying the medical community is that the number of doctors infected and the death among the medical professionals is very high, which is hindering our process. And we are not very in a process going fast to adapt with the new system. So, but still, we have started our classes. Our residents are in the OPD already, and thesis process. Those who are already given the assignments, those who have completed their protocol, they are collecting their data, and we are trying to give them enough time and what it is called some change in the protocol to adapt to the new situation. So they are still working, but this will be much delayed, and there will be lack of skill, I think, in future residents. So one thing I was just thinking about the final assessment. As the assessment, I will also like to hear from our senior faculties and also the speakers that we had a concept of having formative assessments of the students instead of doing the summative assessment, which is not practiced in our subcontinent, even in the UK, I think, but in USA, in the residency program, they do some formative type of assessments. Can we go think about these things in future assessment of our residents? That's what this is my comments about residency program nowadays. Yes.
So, Professor Nazir Laghiri, sir, what about this formative assessment? Do you have any ideas or do you have any suggestions that we can start in this subcontinent, the formative assessment of the residents?
Yes, there is in difficult times you do the difficult things, in desperate times you do the desperate things. And it's already been said that virtual exams or virtual assessments or virtual things can never ever replace the actual things, because the bedside teaching and the bedside clinical presentation and the bedside assessment is different altogether. So we do realize this, but as has already been mentioned, as the time goes by, inshallah, we will get there and we will change with the new. Now they say the normal is coming. It's not a normal these days, but it's a new normal. We will never have an old normal again. So we're going to be facing a new normal in the future, and then we have to assess ourselves which type of exam, formative, subjective, virtual, actual, and every place and geographically is different. and every catchment area is different. So the people have to assess their own situation and devise a system so that our teaching, our learning, our examination must not suffer in the future. And I'm sure all the experts sitting here and all the experts all over the world working very hard on these points that how to go forward. And probably in the future, we have to devise some kind of new measure, some kind of new things so that our working, our teaching, our learning, our postgraduate exams and undergraduate exams should not suffer. And hopefully, this will be done. As the time goes by, time is a great learner, and we are learning every different day. What we learned in March when COVID started is entirely different now. In August, it's entirely different. What we were doing in March, we are doing different things now in August. And hopefully, what we're doing today, we will be doing different in December down the road or even next year. So we all are working. You're all expert. We're all working on the positive side of the thing, and hopefully something will come up for the betterment of the students, for the betterment of the teachers and the university institution. And as the time goes by, we will evolve a system by which we can arrange a comfortable system, which is not only acceptable in other countries, but is acceptable in foreign land as well. So whenever postgraduates go and apply for the jobs in foreign lands, Europe, America, Middle East, they should be accepted as well. So we have to think of that kind of assessment, which assessment is internationally accepted, so that our graduates do not suffer the future plans that they have in their mind. So yes, I agree with the professor, and we will, with the time, will hopefully resolve this issue as the difficulties come, as the hardships come, and we take a face of it and we will resolve. I'm confident we all experts there, you all experts there, we will come to this problem. Thank you.
I have a question to Namrata Sharma. Naman, once upon a time I heard that in some of our universities they are thinking that there should be one software how we can take the examination. In your country, in the postgraduate examination on ophthalmology, is there any software development that in this way everywhere this examination will continue?
No, I don't think that is there. They have a syllabus that is all, but the method of the way the exam would be conducted is not there. It is more structured for DNB exam, where they have given a structure saying that you have to have so many OSCEs and you have to have hot cases and you have to have long cases, but that is only for DNB. Otherwise, all the colleges are conducting as per whatever the norm.
According to their own. Okay.
Thank you.
Naman?
I have one
I
question.
have a question.
Okay.
Just
Yes,
Okay, ma'am.
Professor ma'am.
to Namrata. Yes, Namrata, thank you so much for your excellent presentation. Really, I've learned a lot this time. You have explained so nicely, elaborately. But I have one question about DNP. After graduation, this exam has to give everybody, or the MS student after passing the MS, they are facing the DNP.
Yeah, what happens, ma'am, is that some of the students are able to get into MD or MS, but they do a diploma in ophthalmology. They are not able to get into a degree course. So DNB is a degree course, and DNB centers are not government, but DNB centers are private. Like Sir Gangaram Hospital will have a DNB, or Center for Sight will have a DNB. So, but they will not have a MD. The private sectors will not have a MD because they are not affiliated to any university. But DNB is equal to MD. So generally what people would do, people who are not able to get into MD, they will do a DNB. So if they do a DNB, it is equivalent to MD. And there are some MD students also, just to add another degree, they've already studied for 3 years, and then after giving the final exam, after 2 months, this DNB exam happens. So they will just apply for a DNB and get an additional degree. but they both have
That is additional.
Additional.
Okay. One thing again. As because in Bangladesh, MS course is for 5 years, and also fellowship course FCP is for 5 years. But your one is 3 years, and also in Nepal also in 3 years. So MS, how is it possible? MS course finish within these 3 years.
And we have first year, second year, third year students. So what is generally done is as soon as they come in the first year, thesis is allotted to them. So within the first 3 months, they get a approval of ethics committee. They start their thesis. Thesis period for them is 1.5 years. So 6 months or rather 9 months before their final exam, they are already done with the thesis. Then we have 6 specialities like we have everywhere. Then they are rotated in these 6 specialities for a period of 3 months each. So in one specialty they will come twice. So suppose it's retina. So as a first year student they'll be posted first semester. They'll be posted for 3 months in retina, and when they become after 1.5 years, when they complete one cycle of six postings in 6 different subspecialty, they again come back to retina. So in year 1.5, when they finish, they'll again come back. So in each of the subspecialties, they have 3 months posting of each subspecialty. And last 3 months, they are posted in a unit, but they are made relatively free because they have to study for the exam. So they will not be doing duty.
So can I ask you a question, Dr. Namrata? Then what about those MS students coming for clinical training in ophthalmology? Do they go, before coming to this residency program, do they go through any basic science exam or anything like that? They don't have to go for any basic science.
They don't have to go for
traditionally, we just, in the phase A, we try to teach them something more about the basic science. At the same time, some exposure to some allied subjects like neurosurgery, ENT, and everything. They rotate there. That's why we take little more time.
Yours is more time because we don't rotate them in neurosurgery or ENT or anything like that. They are in ophthalmology only. In the beginning, we might take classes of anatomy related to eye, physiology related to eye, refraction, optics. Those basic classes would be taken in the first 3 months or first 4 months. Basic statistics, basic how to write a protocol class. So those things are taken in the first 3 months. But they don't go to allied branches.
So we are spending 2 years for this preparation. We are not very much sure that whether this is a long time for this, but we are giving some time for basic science and other rotation, biostatistics and research methodology.
Thank you, sir.
Namrata.
Thank you,
I have
Hi, Salman.
Yeah, madam, now you don't give any exposure to the other short appointments like neurosurgery, ENT, and all that basic medicine for trainees at any given time of their training period?
No, not in MD and MS ophthalmology. There are cases which are related to neurosurgery, something like a TCR or something, some patient so they can go across the hospital and consult those consultants, but they are not formally posted in allied branches.
Yeah, I know it's a stupid question that my question, but Indian ophthalmology is not any inferior to anywhere in the world, but it's in the top. But in Sri Lanka, we always give the opportunity for them to go to neurology appointments and mainly neuro and the ENT and basic medicine, at least 2-3 weeks appointments we give. I mean, that increases their exposure to that. And
In our country, in Bangladesh, we expose the students to the neurosurgery, ENT, endocrinology. We also give them anesthesiology. They go to radiology, and also they have the exposure to rheumatology. In this way, they are rotated.
So for us, what happened when Dr. L.P. Agarwal made RP Center, and based on that, all the other institutes are made. We have in RP Center itself in-house ocular microbiology, ocular biochemistry, ocular pharmacology, ocular pathology, ocular, all those departments are there, community ophthalmology. So if you see, I mean, we have 7th floor buildings, so 7th floor is only community ophthalmology, sixth is, ocular microbiology, ocular path. So all those are there. They are generally pathologists, or they are MD paths, but they have been appointed as faculty in ocular pathology. It is like that. So they are anesthetists, but there are special posts in RP Center for ophthalmic anesthesia faculty. So they have been, posted there like that.
A question from the attendees, please. I'm asking these questions to Professor Abdul Kader and Professor Sarar Alam sir, because you are in one of the largest institute in Bangladesh, and then to Professor Sagur Narayan Joshi also the same questions. After breaking the lockdown period, a lot of patients are coming to the tertiary eye care center, and already they have suffered a lot. So there is a huge crowd now. So and all the residents have to go to the crowd and they have to examine the patient. So it's a psychological stress to the residents. And my first question is, how do you handle it? And what is your planning of duties to the residents? Because as it is a very huge crowd, so how you are managing this problem? Professor Abdul Kader.
Thank you very much for your nice time demanding questions. This is also a question from my side. In National Institute of Ophthalmology Tertiary Hospital in Bangladesh, the government setup. Before COVID era, there are approximately 2,000 patients per day in OPD patient, and during the COVID era, it is now in this previous month and this month it is about 1,000 now, 800 to 1,000 patients now. It is difficult to maintain the social distance. We are facing this problem now very much. We have very much regulatory system in entering the hospital. Before entering the hospital, we just check the temperature as well as other primary features of COVID, and they enter the hospital campus, and all the patient we have some volunteer service to maintain the distance. But it's difficult to at the same time it is 8 and 9 o'clock time. It is very much crowd. It is very difficult. The patient and patient attendees are very much crowded. We are not maintaining this properly, the social distancing. But in case of our residency, we are maintaining this one. In outdoor patient, all the our resident, their duty roster. We have about 20 units in NIO, 20 units, and other 20 units headed by professor or associate professor. And every day approximately 7 units are working every day in different situations, different subspecialty clinic, especially retina, glaucoma, cornea, and oculoplastic department, and also pediatric ophthalmology, and also general OPD. So there is patient there is go their different destination and they make their distance. But the scenario is about every 2 weeks one ophthalmologist is affected in COVID. This scenario is the arrival, and we are restricted the operation, routine operation. It's still only 2 to 5 cases per day in routine operation, especially cataract operation on the emergency operation. In this situation, we are controlling the situation, but we are not much more that level. What we want, but in postgraduate student, they are very much suffering from their education, because our morning session from 8 to 9 it is already postponed and it is only June, and clinical classes from 9 to 12 it is almost nil. Only few students are attended because they are in roster duty. Every student on about 1 or 2 days in clinic duty. So this is one of the scenario, and they also in emergency duty are also in 20 units every 1 unit 20 days after. So for that reason, the clinical clinical exposure and other things is very much limited. So this is the scenario of NIO. Thank you very much.
Thank you, Professor Sarwar Alam sir. So, how do you manage the residency program in the Islamia Eye Institute in this COVID era? But about the roster duties and all those things.
Actually, what we heard from different experience of different countries, what Dr. Professor Kadir has said, actually, in our institute, till now, 6 ophthalmologists has been affected, including me, with COVID, and it is increasing. And the patient number of the patient, it is because our hospital is one of the biggest private hospital. In the usual time, we attended about 2,500 patients, and when we open to some extent with all the precautionary measures like measuring the temperature, social distancing, masking, and other things what everybody has told, we are observing, but still we cannot actually prevent the crowd. Till today, for few days, we have to see about 1,500 patients in all the subspecialties. So that is a problem of giving service, and ophthalmologists getting infected. And our hospital is giving not only postgraduate courses but also fellowship program and different surgical training program. So as the surgical training program concerned, it is a great problem because we cannot give surgery now. As for the postgraduate courses, we are taking Zoom class online every day, 2 class each day by different lecturers or professors, and we have Zoom morning session twice a week. And as we have not approached the examination days, we are planning to have a midterm exam by ourselves. We think that we will take the written examination and viva like what Professor Namrata Sharma has said, but our students are coming from different places of Bangladesh. They are now outside Dhaka. If they come, they have to come and stay in some of the hostels or where crowding is there. So that risk we have to take. And in a pilot project type of thing, we have taken a written examination of the ophthalmic allied personals in June. In the sense, they will open their mobile phone in the Zoom and show their script. They will say, we have sent them the questions they have written. At the end of the exam, they are scanning and giving return to us. This is one form of written we have tested in the ophthalmic allied personals. And HIPAA and OSP, easily we can take what Professor Namrata Sharma has said and shown in her example. And in the written thing, today I rang one fellow of Royal College in UK to know their experience. He inquired and he said that the Royal College for the next session, they will not allow students to examine patient actually in the case and other thing. Everything will be as Professor Namrata Sharma has. But their written is like a MCQ type of question, which they are taking previously also. And there are multiple questions in short period of time, and the whole setup has given to a agency. And that agency is conducting that examination and they are submitting the scripts. And the number of questions is such that no student can copy, even if they want to. So they have to know and they have to tick everything in rapid succession. As for example, our sons, daughters are giving SAT or TOEFL examination in the local agency. So they are doing in that way. That can be if we find something. But surgical side, other than the wet lab and simulator, we don't have simulator. We don't know what to do. And education definitely we have to protect our students. But at the same time, if we don't produce students and trainee, we have a havoc in our clinical service, because we are third world countries. We need many more manpower. And the question is that, do we have to compromise? Somebody is telling no compromise for giving a certificate, but definitely we see we have to do some compromise. Is it on the duration? We have to extend the duration or not? That is another question. But definitely, each program director has to be innovative. As for example, we have seen so many examples for taking the exam, for taking the example of getting the knowledge of the patient, knowledge of the student. We are moving towards that, but rest of the thing we don't know what to do. And because of the predominance of the COVID infection among the doctors varies so much that sometimes we are planning, as for example, we plan for midterm exam this month, but we have gradually shifted it to next month because many doctors are getting infected and students are fearing to come. So we don't know actual situation, but definitely we have to do something.
Thank you, sir. Professor Shagun, what is the situation there? How are you planning to maintaining this? Professor Shagun.
Yeah, I mean, Noman, do they call you Noman, or do they call you Shams, which is a better way of calling you? Okay.
Everybody is calling Noman, Shams, anything you can call.
Okay, I mean, the better one. Okay, I'll call you Noman. Noman sounds nice. But you asked me the question regarding the mental health of students. Yes, that is a big question. That's a big, difficult. I mean, all my residents are having mental health problems. And I need to respect that. As a faculty, I need to respect them to get the best out of them. If I do not respect their mental health and their status, I will not get the best out of them. So how do I do that? First foremost thing, to help them improve their mental health, make sure they are well protected. So make sure that the hospital supplies them the proper PPE, all the sanitizers, the PPE, the masks, the goggles, the shields, all are supplied by the hospital. The hospital supplies it all. If there is any damage, we replace it. So that is number one. So once they think they are well protected, they are ready to examine the patients. So then that way we can increase the number of patients. And we also make it a point that if any of our students are somehow exposed to a patient of COVID, we make sure they are quarantined and they get their PCRs. And until their PCRs results don't come, they are quarantined. So we make sure that this is done for them. And we also do not like the more exposure, like some of you, Dr. Alan said, you see 1,500 patients. I mean, my God, how do you see that? And I can imagine why you got infected, because you were seeing such huge number of patients. I mean, this is a time, this is not normal times, this is abnormal times, abnormal normals. So we decided that we will start with the quota system. Initially, we started with 25 patients only. And we said, yes, we can increase the number of patients. So we started gradually increasing the number of patients. Today, we are 50 to 60 patients in the first session. And in the second session, we have around 20 to 30 patients. But depending on the situation, we are increasing the number of patients. Some of the patients require emergency services. When they require emergency services, we do not refuse that. We have a separate wing for emergency services, and all emergency services will get their emergency service. Now, regarding, the crowd management, it's quite difficult to manage huge crowds. If you open the OPD and don't put any quotas, you will see a number of patients, you'll see 100, 200. So we decided that we will have spotters. We have 2 spotters outside. Actually make sure that we set those rings where actually the patients make sure that they are sitting or standing on those rings. We maintain that social distance, no crowd outside, and we have written a notice there. This is the quota. Once this quota is over, if it is really an emergency situation, there is a counter there. They can approach that counter, the triage counter, and if we think that it's really necessary to see the patient, we do see the patient. So this is how we are managing, making sure that none of our students as well as faculties are infected. Once infected, I mean, it comes out in the news that this hospital, so-and-so doctor got infected, automatically the patient decreases. Moreover, of course, in the COVID time, the number of patients has definitely decreased. We don't have to decrease automatically; it is decreased. But to protect ourselves, we are still maintaining the quota system. And since the number of cases have again graduated after the lockdown opening, which will happen, of course, the cases have again surged up. So we have again gone back to a quota system, division of our groups into further subgroups, so that if one gets infected, it's in one particular group, it's not the whole people, we don't have to go into quarantine. So we are meeting to subgroups and making sure that we are well protected and we respect the health. Unless and until we are healthy, how can you make others healthy? So we need to be healthy first to make others healthy. So that is my advice.
Thank you, Professor Sagun Joshi. What about the issue about the doctor's health? So this is very much important. This is the utmost important. You have to take care of that, no doubt. But my question is, why the doctors in Bangladesh and also I don't know what about the India, the doctors are affected more, even though the ophthalmologists are affected too much in our country. So what may be the causes and how can you prevent this, Professor Hazrat Ali sir? Do you have any comment on this?
Yeah, I think we've been quite protected because I told you, one, the PPE is number one important. The social distancing, which we are absolutely maintaining it, sanitization, and we also make it a point where we have a spotter. A faculty itself is a spotter who actually his job is to make sure that all my residents and other faculties are also maintaining. Because when you are seeing a patient, you forget many things. Because this is absolutely abnormal. You'll be talking and some patient will be behind you, somebody will be coming. So there is one fellow who is the spotter who actually goes and sees everybody and maintaining that. We go and correct that. Now we've already reached this system where we have mastered that. So everybody maintains their social distance, has the proper PPE, and everything is in track right now. So we as such are much more well prepared.
Thank you. I am the question from. I want to comment from Professor Hazrat Ali sir. Professor Hazrat Ali, please unmute yourself and do a comment on this, please, sir. And then Professor Nazir Lahiri.
Yes, Professor Joshi, if I may ask you, please. I know that you apply PPE to the physicians and the doctors who are examining the patient. Do you do any protective measure for the patient to visit you? What kind of things you do to the patients before they come into your visiting consulting room? I think that's most important as well. So every place, everybody, every hospital do the different things. But I would like to your idea what you do in your place.
Okay. The first foremost thing, we have a triage area where I told you the first foremost thing, if we have if the patient is from a hotspot area, the patient is from a hotspot area, the patient goes to or we suspect that this patient may be COVID. We send in the triage fellows send it to a COVID group. So that takes care. There is one special resident who's really well prepared to make sure that we are dealing with COVID or suspected COVID patients. That is one thing. All patients before their entry, as you all are doing thermal scans, but we've not tell you frankly, we have never. Most of our patients who have been COVID positive have been asymptomatic patients. We have not had patients who are symptomatic and coming into ophthalmology. We've never had that. We've had temperature checks. There was a couple of times where the temperature was high, made the patient rest for some time, the temperature came to normal. So this temperature check is important. But where most of our patients are asymptomatic, this is not helping very much, but we do the temperature check. And once they enter, before they enter, they make sure that we have the sanitizer, they sanitize, and we make sure that they have a mask which is covering the full nose and the mouth. Because many patients do this. They will come inside, they will start walking around. We make sure that once the patient comes inside, the mask is worn. The spotter's job is that. His job is just running around to make sure that the mask is properly worn and the patient is seated in a place. They are given a place to sit and they are not allowed to stand or move unless called. We do not allow the patient to stand or move because once they stand, they move. When they move, they carry the virus and they start. Phone calls, we don't allow phone calls inside the exam in the waiting room as well as in the examination. And we have a guard where we counted the number of chairs. We have like 50 to 60 chairs, and we have made so at a time we only allow 15 to 20 go in with a visitor, and they are given a special place to sit. And the guard controls it. Once we have 2 or 3 patients, 4 patients move out, then we allow the next 4 or 5 patients to move in. So we control the crowd this way. In that way, we've been able to manage our patients very well, and we are very confident that hopefully none of us will get infected. Recently, we had patients of COVID coming to, they were asymptomatic, but later when they did the PCR, they were tested, and a lot of us, we did our PCRs, we were well protected, we went into quarantine. So far, none of us have got it.
So I have a question, Professor Hazrat Ali sir. I have a actually, what about the what are you thinking that crowd is a problem, the PP is a factor, lot of protection is a factor, but what about the can you please explain that? Is there immunity can be a factor? Do you think that the ophthalmologist or physician they are less immune person that they can be affected with viruses? What is your comment about this?
Okay, can you hear me?
Yes, sir. Yes, sir.
Yeah. First is that immunity is a big important factor here, because today I listened to the reports from the sub-Saharan countries like Uganda, Kenya, and Mozambique, and other countries. Their report is that the death rate and morbidity and mortality rate is so less. It is 100 times less than that is happening in USA and UK. And the explanation is that the immunity of these people in this sub-Saharan country, even though they are malnutrited and they are suffering from malaria, HIV, other things, still they are being protected by the different type of infections going on there, like other coronavirus infections. In Bangladesh, there are some started in the slum areas. In slum areas, they have found there is almost nil infection in Bangladesh. Slum areas, no death. So this is one important. And number two, the doctors work. Now it is very hot and humid atmosphere in Bangladesh. And doctors working in the hospitals, if they wear a PPE and with mask, N95 mask or double mask sometimes they use, and other shields, they are sweating, and when they are sweating, they have to frequently wipe it out. Otherwise, the glasses becomes heavy. So they remove the glass and wipe and again put it in the eye. Like I have talked with some doctors working with the COVID hospitals in COVID patients. They told me that it is very difficult to work with the PPE. When after 15 minutes, yesterday one of my close doctors, he became fainted after 1 hour. Young doctor, due to this humid conditions. So there is also crowded now. So I think all this condition is having impact on this more infection in our doctor society, and so we must be more careful about this. Thank you.
I want to add to Professor Hazrat Ali. One thing is that the patients are asymptomatic. Most of the patients are asymptomatic, and we should think that all the patients are COVID, and according to that COVID patient, how we can protect ourselves. this should be our attitude. That's because
Yes.
5 ophthalmologists, you see, 5 ophthalmologists have died. About 100 ophthalmologists of our, among 1300, they have been attacked. So we should be highly protected, and we should be careful not to be attacked by coronavirus. Thank you.
So there is another issue about the exam. I'm on the exam issue. All the residents or those the students will appear the exam. They have some stress. This COVID period, like family stress, like their parents are affected, they might have affected, their children can be affected. So in this period, they will give exam and a virtual exam. With that exam, they are not actually habituated. So what is your thinking about the little consideration of that examining for the exam actually? Do you what is your planning? A little bit. I'm telling about the little bit consideration of that psychological stress of your examining.
Can I give a comment on this?
Yes.
During our, if we remember our liberation was 9 months, our schools and colleges were almost all closed. Maybe 5% students attended the school and colleges, and others didn't attend. 95% didn't attend. But after the liberation was, there was exam, and the government considers the syllabus and everything, so that the examination was taken, and with this reduced syllabus, the exams was taken. I think during this COVID, for this COVID, it is only 6 months now. Maybe we can wait a more 4 months or 5 months up to January. If this situation does not improve much, we should take the exam with a reduced syllabus and without life pressures also.
And because
Dr.
you have
Salvin,
already
Dr.
learned,
Salvin,
Naman,
Sir.
I will add one thing that in other situation, that is in our school, colleges, they are thinking that they will reduce the syllabus. In our medical graduate, postgraduate, undergraduate, everywhere I think the syllabus will be reduced, but we have to take the exam. But if it necessary, only 6 months we can reduce from their total tenure. In this way, we can proceed, and it will be very much helpful. But we cannot ignore all the examination. Examination should be taken from everyone for the student.
Professor Abdul Kader, what is your opinion about this?
My opinion, the syllabus is not to be reduced, but we may be liberal, as because there is a skillness of the surgery as well as clinical skillness is very much limited. For that reason, we can consider this in these sectors, not otherwise. I have one question regarding virtual as well as clinical examination. Can we arrange any orientation before final examination in this situation? What about this regards opinion from your side?
I think Professor Namrata Sharma can give some idea. Before that, there should be an orientation. Professor Kadir has rightly mentioned that there should be orientation how the examination will be taken. Otherwise, the patients, the students will not be able to cope up, and they will not be able to appear in the examination. So, orientation is a must. I want to know from Professor Namrata Sharma.
I think orientation is a must, and that is something that we didn't do. But like Dr. Abdul Kadir sir said, that you have to be liberal. I think that is what we did. We were liberal in marking them because patients are not there, surgery is not there. They are under mental stress. We are under mental stress as well when we take the exam. And then suppose you fail a student, how do you justify that in the COVID times yourself, or how does the student also feel? So those kind of things are there, but I think orientation exam can be taken beforehand. You can have a preliminary
virtual.
Like earlier you used to have cent-ups, or you used to have pre-professionals like that, a pre final exam can be held. And if
Yes.
you want, I can, whatever module that we have and whatever goes into preparing for this, we have
Yes.
the whole SOP ready. So if you want, I can send the SOP to you and to all of you.
Yes.
And maybe you may not do the whole thing virtual, but you can adapt parts from that. So like, for instance, you need not ask them to hold the instruments or don't ask them to open the bottles. So parts of it can be adapted as
Thank
per
you.
your
Thank you,
requirement.
Dr. Sharma. We want to get it from you. Please send us. It will be better for our examination.
Yeah,
The
so
doctors,
we prepared the SOP, we'll send
Yes.
it to you, and then whatever you want to, whatever is conducive to your country and to your university, you can adopt. At least there is a baseline.
Sure.
Dr. Salvin, are you there? Dr. Salvin? Dr. Salvin?
Probably he is not here.
So we are almost at the end of our session. I'm
Yes.
requesting all speakers and panelists to say a few words, 1 minute, few words about these topics and also about this webinar. And we can start with Professor Jafar Khalid, sir. Professor Jafar Khalid.
Everyone 1 minute.
Okay.
Everyone 1 minute.
Okay, thank you. Thank you. I was listening a very interesting discussion about the training program of our residents, their safety, as well as about their about the assessment of this of our residents. This is very informative discussion here. One thing we need to note that although we are discussing all these things, this has to be coming from the central controlling, exam controlling, or the authority. Like university has to adopt the system which we have to cope with, and also the college of physicians has to bring a system which we'll have to have, and we have to be coping with this system. So we can discuss. We have got the information from different countries, our surrounding countries, and that will help us. But regarding the safety of our residents during their training, is very important. I'm really impressed with how Dr. Joshi was telling here how he's managing. Number one is the crowd control. Should not be allowing too many patients entering into in our OPD to consult. So unless we make a control system like an appointment system, how many patients and how many doctors will be seeing in a day, and each of the residents should not see patients in every day. So they should get some resting times. And it is also important that in our university, our ophthalmology residents are attending the COVID patients also. They're working on rotation in the COVID units where they're working as a resident. As well as our consultants are going there. The ophthalmology consultants, they are also attending the COVID units for a round, and they're supervising our residents. So this is very important that we control the crowd. We see minimum number of patients for next few days, 3 months at least, and then let us. That will definitely reduce the number of infections. As it has been said that definitely our Bangladeshi doctors are getting more infected. There must be some break in somewhere, some chain system where the mask, whether we are using this mask, whether we are removing this mask in between our masking period, and our hand cleaning system is working properly or not. That's very important. Dr. Hazrat Ali sir was telling that it's very hot summer days nowadays, very difficult to work with the masking system. So if we can at least reduce the number of patients, this will be one major safety margin for our residents. That's what I want to say. Thank you very much.
Thank you, Professor Jafar Khalid. Professor Nazir Lagheri, sir, do you have comment on this webinar, and how do you feel, and what is your experience on this webinar? And
I think I think it's been great, and I congratulate you and everyone that you have done an excellent job to organize this. And these kind of programs should happen more often than just now and then. And we do learn from each other's experiences, ideas, and views, and that's why we keep attending all these conferences and all these programs. This is a very good thing, and I will encourage you and I will advise you to please do arrange these kind of things on different topics, on different days and different months, so that we can all learn. This is not only beneficial to us, but it's all beneficial to the society, to our students, to our PGs, to our teachers, to in general, to all the public who are listening to us, so that we learn from each other experiences and skills what we have done. Thank you very much, and I hope and look forward that you'll arrange another one very soon, and I'll be glad to join you again. So thank you again.
Thank you.
Thank you, Dr. Lahari.
Professor Hazrat Ali, sir.
1
1
minute.
minute.
I will take less time. I will thank Dr. Najir and Dr. Joshi and Dr. Namrata to share their experience with us. So yes, it will be this whole webinar was very excellent, so that we can have our training programs and examinations depending on the experience. I hope in future also we will share with them our experience, and they will share with us our further experience and new knowledges. Thank you very much.
Professor Abdul Kadir, sir. Because because you have a you did a lot for this webinar arranging, and you have I have to share everything with you, and thank you from myself to you, Professor Abdul Kadir.
Thank you, Dr. Naman. Thank you, everybody, for joining this great webinar. My last comment is it is very much helpful for medical education, because from the Pakistan, Nepal, and India, we also get some information and some materials for running this post-graduation program. As well as in NIO, we trying to start the monthly evaluation on Zoom examination from the next month. This is a new thing we are thinking it, and I think it will be continue. And if we need in future, we also arrange the same type of webinar for medical education. Thank you very much. Thank you, everybody.
Thank you, Professor Saror Alam, sir. Last 1 minute.
Thank you. Actually, hello. Education giving service is everybody interested, but for education there needs to be extra effort and take the burden, and some teachers has to be innovative for the society for teaching. And as I said in the beginning of my saying that if the production of the trainee or students are hampered, then our society will suffer. So we have to think about and we have to do extra effort for their teaching.
Thank you, sir. Professor Namrata Sharma, ma'am, do you have comment about this webinar?
Norman, I think it was one of the best webinars that I have attended in this season, and everybody learned from each other such a lot. And I think it makes a lot of sense, because when you know each other's experience, you can also do advocacy at your. After all, you have to advise your government, your policy makers. You have to tell them. So once you get ideas from other people, you will also advise them accordingly. And the best part about these webinars are that I've been to Bangladesh twice already, and I meet Dr. Awa Hussain madam every week, and I see all of you, once in 15 days, which is really good, which we wouldn't have done physically. But yes, postgraduate teaching, we will have to come to a new normal and keep organizing such programs. Shagun I've met after many years, and physically we did meet, but not on the Zoom. But keep organizing such programs, very innovative, and I think very nice for the postgraduates and for the teachers also. Both.
Thank you. Thank you, Namrata ma'am. Professor Shagun Joshi, you have last 1 minute to comment on this webinar. Hello, unmute yourself. Unmute yourself.
Shagun, you have to unmute yourself.
Unmute yourself. Unmute. Unmute yourself.
Josie, you are not unmute. Please unmute.
Okay, thank you. You now start.
Thank you, Norman, and all of you, especially Sham, Mohammed, Norman. You've been the hero of this movie. I haven't gone to a movie hall for a very long time. Now I feel like I've gone for a movie and I've seen the hero. And you are the hero. Well done. Thank you very much. It was really well organized. You made us feel so comfortable. You made us feel like as if we are listening to friends. Thank you so much. It was really wonderful and beautiful. And all the panelist speakers, you all are wonderful. You made us all feel so comfortable as if you're like close friends, old pals. And another thing, I just want to let you know that we tend to, be very careful when we are seeing patients with the PPE, everything. But we let our guards down in certain situations. And this is when we get infected. And these situations, I myself may go through it. That is when you are with your co-workers. When you're with your co-workers, you let your guard down. You talk to your friend. I'm talking to Sham, so I put my mask down. So you say, so this is co-workers. We have to be very careful with our co-workers. This is the time where you get your infection from. And also from your friends. You trust your friends so much that how can I, not have a drink with my friend? Then you put your mask down and take a drink, and that's the time you get infected. And the next is you want relatives. It's mostly your relatives that get your infection from. These are things that we have to be most worried about. Among patients, we take care. We are very careful. But among our co-workers, friends, and relatives, please be careful. Another thing, thank you. Communication is the way to get the best during COVID times, and this is one way of communicating. It was really wonderful, and prevention is always better than cure. So let's prevent ourselves from COVID. Once you get COVID, we always have some problems. Please stay safe, and please visit Nepal, and please make sure that you come in touch with me when you come to Nepal. We'll take care.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Joshi.
Thank you. I'm requesting our special guest of honor, Professor Abha Hussain ma'am, to tell something. I think it will encourage us. Thank you, madam.
Thank you so much, Noman. It is really a very interactive session. I have learned a lot from Professor Namrata Sharma, from Professor Nadir, Professor Sharfaddin, and Professor Shagun Joshi. All these speakers, they spoke in so nice way their personal experience and also details about the examination. The main theme of our today's webinar is that postgraduate academy. The headline, but Professor Namrata has presented in that way, exact way, the postgraduate examination and teaching, how we will do. That is our aim, that in this COVID era, how we will teach our student, postgraduate student, our resident, how they will examine the patient. This has come up from Professor Joshi, Professor Namrata, Professor Najib, Professor Sharfuddin, and all the panelists has gave their own verdict that how they will move. But the main thing is that the examination body, every country has their examination body. We have also. So we can at least ventilate today's all the recommendation or all the sum up move, and here there are so many faculty, Professor Sarwar, Professor Hajrat Ali, Professor Jafar Khalid, me, and Professor Sharfuddin Ahmed is the best person for Bangabandhu Sheikh Mujib Medical University. He is the chairman. He is very dynamic person, and he can also ventilate this to his vice chancellor and the faculty and the council of the Bangabandhu Sheikh Mujib main examination to just not in physically or virtual in this way we should take as because this time July we all missed our exam. FCPS student they have already filled up the form, but all on a sudden it was declared that not it will not be possible. We can understand it will not at all possible in July as because that was in a peak COVID is very big height, and now it is also not declining, but it is in a static way. So we should we didn't know next session is our January, and up to that I think we can at least take the exam. But what we will take our students exam? Professor Namrata said that we are also stressed, our students are also stressed. Of course, this is the real situation as because they didn't learn anything. They didn't learn anything within this COVID era time. Now, all the students are ringing the what we will do. We student resident, not in Bangabandhu University, not in NIO. All in medical college, there are also postgraduate institute, postgraduate course, and that student they are very much sufferer as because they could not see any patient. They can see the patient weekly, but no teaching, no teaching. Professor Jafar Khaled, Professor Kadir, they have said that the clinical teaching is no more now, but the resident can see the patient in the outpatient department and affected why our doctor the mortality rate is also very high as because not only that immunity is of course a very big thing. If a person has immune, he can overcome the COVID, but the aged person, 60 up person, and the children also, these are the very much vulnerable and the comorbidity. Everybody has diabetes, hypertension, some malignancy, and other comorbidity. These persons are very much vulnerable. If COVID affect that person, they should very difficult to come up. So that is separate entity. But the thing has come with the PP, with the masks, with the shield, everything that is proper PP. And the main thing, the affection when they are remove the PP. That is the time that there must be some error in removing the PP, and that is already has affected the virus has affected the person. I don't know the doctor who are just first line, that is the front line in the ICU. They told me that they have their course for 2 to 3 days before starting their duty in the ICU, and they said that at that time this is very important how to remove the mask, how to remove the shield, how to remove the PP. This is very important. So not you can remove it and just keep it in one, but not that. You have to dispose in the waste. Dispose is very important to re-affect or to affect the doctor as well as the other person also who are beside you. So this is other entity, but main thing, the main theme is our student, main theme is our examination, main theme is our teaching, and that has I have learned from you, Professor Namrata, Professor Shagun Joshi, Professor Najir, and Professor Sharfuddin. They have elaborately discussed, and all the panelists has already repeatedly. No one has given time repeatedly to say to give contribution about that. So I think there will be in our January session, there will be a definite good exam, and that will, of course, both physical and if it is possible that it is as because postgraduate student, they are in divided if 20 students you are not taking in one day, there are 3 days or 4 days like that. So if in that way, with all the PP and with student can some of the patient very reserved way, and then they can give the oral exam and all others by virtual, then we can at least have the satisfaction by giving the certificate that yes, they deserve it and they achieve it. Not we are by cutting our syllabus or by liberally we are giving the degree to them. No, not that. They will take that by their own and achieve the degree. Of course, all examiner will be liberal at the table to the student. This is our characteristic of the teacher. And with this normal new life, this should be to every and each and every teacher and every body for the feelings of our students, for the feelings of our patients and fellow feelings and all. So very interactive, very nice webinar. Namrata said that she at least I think 30 days she is attending webinar. Every time she just before our webinar she was engaged in another one, and this is very good thing for AIOS. I have told to my president Professor Sharfuddin that they every faculty, every subspecialty, they are giving honor to the president and honorary secretary of AIOS. Is it Namrata? Everywhere they are giving the respect, and they were these 2% are the best person, and they are the main heart of the society. So they were present in all the subspecialty. So this should be in every country and everywhere, as because our president, our secretary general, Professor Abdul Kadir, they are all two are the dynamic person, and their hands, Dr. Noman, everybody knows some Noman or Noman, we call him Noman. So he's very dynamic one, and he is always trying to make the webinar. Madam, how you will you please say me that whether you are free within this date, this date, this date. So that is the way they are just pushing us, and we are with them. And Professor Sharfuddin, Professor Sarwar, I didn't mention their name. They are for Kale. I didn't, just once I have seen his face, but his blog, his video, and I think he's not here now. So Selvin is also a very good friend, and all of you. And this is the time for dinner, and this is the time for good night. So,
yes, Madam, I'm listening to you. Thank you.
Jafar,
I'm requesting
and you have given a very good contribution. You have said
Thank you, Madam.
About Bangabandhu Sheikh Mujib Medical University. You are the chairman. Professor Sharfuddin is the chairman, and Professor Sharfuddin is not only academician; he is the politician also. So he is very every day he is giving talk show in television. So this way we are trying compact COVID. Now I don't know what will happen, and so let's pray for everybody. I myself pray for everybody, for the whole world. God please help us. from the COVID. With these few
Thank-
words, thank you all. Thank you very much. Professor
Thank you.
Najir, Professor Shagun, Professor Namrata, Professor Sharfuddin. Professor Sharfuddin is not the leader, but he's also my student. This is a very proud privilege for me to say Professor Kadir, Professor Jafar Khaled, Dr. Noman, Professor Hajrat Ali, and all the foreign faculty. Thank you so much. Thank you.
Thank you, madam. We had a very compact session, 2 hours 23 minutes. Thank you. I am requesting Professor Sharfuddin Ahmed sir to conclude the session. Sir, please, time is yours.
Thank you. 2 hours 23 minutes. I will take 2 minutes only, and then it will be the number 225. Thanks to all the speakers, including me, and Dr. Professor Najir Laghari, Professor Namrata Sharma, and Dr. Shagun Joshi. And
Hi,
yes,
hi, Salin, I also need to give few words.
yes, okay.
Yes,
Before me,
we
you
have
can.
searched you.
Yes,
We have
Salvin.
searched you.
Salvin,
Okay, fine.
Okay.
Salvin,
You can give a
Dr.
comment.
Salvin,
Fine.
we didn't find you. Salvin, Dr. Salvin, we didn't find you.
Nice.
Yes, you can tell. And
it's
after
on your video.
You know,
Dr.
no,
Salvin.
I was actually, my video was muted because the signal strength was not that good. That's why
Okay.
I can see you all, but I have cut down my video. But anyway,
Okay. Okay,
this is a very interesting session. You know, my experience during COVID team postgraduate training is not that much because we were not affected badly, but we had to shut down everything for 3 months. But you know, this session was really interesting. How you deal with this sort of condition. You know, I mean, we cannot guarantee that we will not get the second wave and the country will have to come to a standstill. In that case, we know how to deal with. I learned a lot from you all. Thank you very much, and it's very interesting. But you know, I am always a positive thinker. I think the future will not be that bad. It is always better to be prepared, but things will not be that bad. It will go over very soon, hopefully, and we will be able to conduct the exam. Thank you very much.
Thank you, K.
Thank you.
Salvin. Hope for the best. From your last speech, that is hope for the best, and we will overcome everything. We
Sir, I have an information to you, sir. Sir, I have an information to you. Dr. Salvin is going to be the president of College of Ophthalmology of Sri Lanka.
Oh, very good, very good. Congratulations.
Congratulations.
I invite all of you to come and give a lecture in my country once I
Yes, we will come. We will visit your country, and we are hoping that this COVID will be off, and then we will meet face to face, not like this today's webinar. Thanks to panelists, K. Salvin, Professor Jafar Khaled, Professor Sarwar Alam, Dr. Shagun Joshi, Professor Namrata Sharma, Professor Abdul Qadir, and Professor Hajrat Ali. And I think I should give the special thanks to Dr. Shams Muhammad Noman, who is the main coordinator and dynamic personality for this webinar. He has collected all the dignitaries from Pakistan, India, from Nepal, from Sri Lanka, and Bangladesh, except Bhutan. Probably in future we will collect someone from Bhutan. I thank all of you for your contribution. Today, this thing was recorded. Along with this, Professor Namrata Sharma will send some of the virtual examination procedure that will be also collected. I hope I and Professor Jafar Khaled will be in the academic council of our university, and we will also invite someone from PCPS or other institutes, and we will be able to give the information how we can proceed for this examination. I think this type of webinar can give us a lot of knowledge and attitude that we will be able to perform all the examinations among the students. Today's discussion, not only the examination, our safety, our doctors, why they are becoming more affected. So our safety should be there, and this should be by three things. One is avoid crowd, and then PPE and donning and doffing, as well as we should be careful from our relatives and also from our co-workers. This should be a very good thing from today's discussion, and I think everything will be normal very soon. But before this, new normal life should be like a different steps, and these steps should be taken by all of us. And I hope today's webinar have given us a lot of idea, and we have a lot of knowledge from different countries, how they are running their postgraduate courses, and how we can proceed, and how we can make it more stronger than previous. But we will not be liberal. We will give the degree to the students with their own matching. Professor Najil Lagari has told us that when another webinar will be there, he will be with us. We hope another webinar we will arrange very soon, and up to that, I will hope that everyone will be healthy, and hope for the best with these few words before ending. Tomorrow is the Independent Day of India and Pakistan. Isn't it?
Pakistan today.
Pakistan today, and tomorrow is India. And I will show deep respect to my father of the nation, who was assassinated on 15th August 1975. Tomorrow is that day, so I show deep respect to him and others who was assassinated on this day. Before ending, this was the deep respect, and I hope all of us will show the respect to our father of the nation. With these few words, thank you very much for joining us, and we hope we will see together.
Assalamualaikum. Good night. Good night. Assalamualaikum.
Good night.
Amrita, again we will see you.
Thank you. Thank you.
Hi, Namrata.
Thank you. Thank you.
Thank you.
Thank you very much for joining.
It's always
Thank you, Professor Abdul Kadir. Thank you, Namrata ma'am.
Yes.
Thank you, madam. Thank you, Abha.
Thank you. Thank you,
Thank you.
ma'am. Thank you,
Both the
madam.
madams are
Thank you very much.
with us, Professor Abha Hussain, Professor Namrata Sharma.
Thank you.
They are leading whole world now.
Yes.
Thank
I'm
you.
trying to follow Professor Awal.
It's our leader.
Yes, our leader. And we will be with them a long period, inshallah. Thank you, eh?
Thank you.
Thank you very much. Thank you, Chakravarti.
Thank you.
Thank you.
Thank you, ma'am.
ভালো থাকো, ভালো থাকো।
Ji, madam, assalamu alaikum. Kadir bhai, assalamu alaikum. Thank you.
Well done, very well done.
কাদের, ভালো
Ji,
থাকো।
ma'am. Thank you. Assalamu alaikum.
Assalam.
এই নোমান ভাই ঠিক আছে পরে কথা বলবো নিজে খুব সুন্দর হয়েছে
থ্যাংক ইউ কাদের ভাই আপনার সাজেশন ছাড়াই তো হতো না আপনি যেভাবে সাজেস্ট করছেন এক্সেলেন্ট জি
অনেক
ম্যাডাম
সুন্দর হয়েছে, অনেক
ম্যাডাম
সুন্দর।
কাদের ভাই আমাকে সাজেস্ট করছে সুন্দর করে গাইড করছে
কাদের তো আমি তো সবসময় বলি